Hey, how you all doing? It is Monday the 6th of April and it is 7:25. I didn't vlog this weekend and that wasn't because I was off, it was because I was working, but I was on the non-COVID part of the hospital. The hospital over the last week is really unrecognisable in terms of patient flow and in terms of what we're doing. So many changes happening. Because I've been on the non-COVID side, I wanted to talk about how COVID was impacting the other services we offer. So in terms of the emergency department, when patients come in, we're actually triaging them at the front desk, whether they are likely to have COVID or not, and there's this kind of screen using many of the symptoms. And we've had a few patients in that didn't have obvious symptoms of COVID-19, but then after we take a history and get our bloods back, there was a suspicion of it, which suddenly means you've got a bunch of patients in a bay with one person with, possible COVID, and that's exposed potentially the patients there and potentially the staff as well, because we're wearing less precautions than in the COVID side. This is an impossible thing to be able to do, because what's the alternative? You put everyone in a COVID area and then you're exposing everyone that doesn't need to be. So we're trying to do the best we can. So over the course of the day we had 2 patients that arrived in the clean area that we thought might have COVID. The difficulty with that is that we then have to take all the patients out the bay, deep clean the whole bay before bringing all the patients back in, and it's just one of those things that's going to happen. And likewise, we're going to have the opposite thing happen in the COVID area, like people that we feel like might have COVID. So for example, someone has a bacterial pneumonia, but we can't tell the difference at triage. They'll go in the COVID side and potentially expose themselves to patients around with COVID-19. That's why the advice to stay away from the hospital, if possible, is good advice. The difficulty as well, the second point, it kind of goes against the advice I've just said. In a sense, we're seeing loads of people come into hospital, very late presentations of other diseases that we have good treatments for. So heart attacks, strokes, complications with diabetes, people presenting late with falls, so having a fracture for sort of more than a day and trying to, get through it. If you have a medical emergency, you must come to the hospital, because things are going to be much worse if you delay things like heart attacks and strokes and serious infections. So we're still here for you, and I know in other countries that they're seeing bad outcomes where they traditionally have good outcomes because people aren't coming into hospital. That is making the job more difficult as well. So when I'm on the non-COVID side, I'm seeing much more complex patients than I normally would, because they're presenting late or they can't get access to things like palliative care services or GP services for a while, and then they come in really as a crisis. This is just a knock-on effect that we have to deal with. So my advice to you would be, if you have anything that you'd normally come to the hospital with in terms of an emergency, then please still do it. We're happy to see you. So I'm off on my shift. I'll probably be on the non-COVID side again. I think we're supposed to be doing 50-50, but as I say, my last 4 shifts, 3 of them have been non-COVID, which is fine for me, but you have to share the burden on the team. I would hate for one of my other colleagues to be in and feeling like other people weren't sort of putting their weight in. I think it's because the shifts I've done this week just weren't quite compatible with going into that area. It wasn't busy the times I came on shift. So I'm going to keep you posted on this one. You're going to come with me today, and whatever happens at half time, what I'm going to talk about is how we manage a patient when they come in with COVID, so all the extra stuff we need to do. So my first week on the vlog, I talked about how I'd normally approach a respiratory patient. I'm going to talk about how we'd approach someone with COVID and all the different things we need to do and think about when we see someone with the illness. Let's crack on. So I'm off out. Sonia's just come in from a busy day on ICU. How are you doing? You well?
Yeah, it's busying up. It's starting to get to be what we thought it would be. Region's getting very busy, our hospital's slightly less so, but yeah, it's feeling very real.
We sort of get an idea from the other regions, don't we, of what to expect.
Yeah, yeah, I mean, hospitals not very far from us are seeing 5 times as many ICU patients as they would normally have. Wow. And that's putting a serious strain on their services, although they are all managing so far.
You personally, you well? You good?
Not so bad.
Alright.
Difficult when you lose patients. Today wasn't a great day from that point of view.
Oh, Sonia, but you're off tomorrow, right? So you can reflect
tomorrow.
On things.
Bit of time to relax tomorrow.
Cool.
Yeah.
Good on ya. We'll catch up with you later. Bye bye. You should recognise this place by now. It's the car park chat. So we're about to come on shift. things I want to focus on today is just to be extremely meticulous in using all the PPE, in doing my plans right as well. I know when I was on the COVID side before, you want to limit the amount of times you go in the room, so every time you make a small mistake in terms of not getting something from the history you need to, or not setting up the monitors correctly, I want to limit all that. I'm going to really try and slow things down, keep it super safe, because as Sonia said just now, and what a superstar Sonia is, we've actually got the time with patients here at the moment, so I'm going to try and really develop some new good habits. And even if I'm on the non-COVID side as well, which I'm happy to do, and I'm feeling confident in that area now with our, the type of PPE we're using, and also gauging who needs to come into hospital as well. It's changed basically. We want to try and keep people at home as much as possible, so I'm adapting to that, feeling more comfortable at that. I'm feeling really good today, despite it being a Monday night and having worked all weekend. I'm feeling really confident in what I can help out and what I can deliver, but I have been noticing some of the staff a little bit more stressed over the last couple of days, so I'm going to try and really support everyone else, try and get them to buzz off some of my vibes. So the time is 3 in the morning, halfway through the shift, and I've just heard the news that Boris Johnson, our Prime Minister, has been admitted to ICU, so my thoughts are with him and his family. We know how devastating this disease can be, so I really wish him all the best, hope he pulls through on this, and I know there's a great team looking after him down in London. Today, dare I say it, it's been another quiet day. I've been on the COVID side. I don't know if you can tell, looks like I've got some goggle burns. That's just from the tightness of the mask you have to wear. I've been seeing patients with COVID today. Patients pretty sick, but also some sick people that clearly don't have COVID but have more general infections, but we don't know they're not COVID when they come in. So those patients we do have to treat in this side and run the risk of exposing them to the patients here. Obviously we try and mitigate that as much as possible. It's been an okay shift. I haven't quite been where I want to be, but it's a work in progress, isn't it? So many new things we're having to do. I wanted to talk about kind of the patient flow when people come into A&E. Most of the people really struggling with their breathing from COVID will be coming by ambulance, and the ambulance will pre-alert us, so they'll call the hospital and we'll allocate a bed for them to bring the patient in. That stops the patients kind of cohorting, so waiting in the triage area and then potentially infecting people there. So the ambulance would deliver the patient into the room and do the first set of obs. The ambulance crew would be in their full protective equipment. So we put the patients on the far side of the room, so when you come in you're having minimal exposure. Make sure the patients have a surgical mask on as well to prevent any droplet infection. We'd then take the handover from the ambulance crew, read through the notes and maybe look up on the system the patient has any other problems. We'd then get in our full protective gear, and normally we go in as a team to assess the patient, but it would just be one of us. In the area I'm working in, we have the mask on the whole time and a gown on the whole time, and we actually just change our gloves and goggles when we see the patient. So we then enter the room. We don't take the patient's notes in with us because that could get some infection on and then come out. So really when we go in to assess the patient, we want to get the history, so find out exactly how long it's been going on, what symptoms, and make sure there isn't anything else we're missing, because as we said before, patients can come in with other things rather than COVID. And we'd really limit our examination because we're just going to be exposing ourselves to the patient. We get the patient's vitals, so their observations, so their heart rate, blood pressure, respiratory rate, their oxygen saturations and their temperature, and we'd hook them up to a monitor and turn the monitor out so we can see in through the door, so we can see what the vitals are, so we don't have to keep going in to see the patient. And looking at the oxygen sats, we can tell if patients need any oxygen straight away. If we're worried about the saturations, we might want to do an arterial blood gas. That tells us things like how much oxygen's in the blood, how much carbon dioxide, the pH of the blood, and other things like the electrolytes as well. That can be really important, because if someone's super unwell, that's one of the vital things the intensive care doctors will want to know to assess, how well the patient's oxygenating or how tired they're getting with their breathing. We'd also take some blood tests and pop a tube in the patient's arm called a cannula, so we can give any medications if we need to, and we get an ECG, so a trace on the heart. Before stepping out, you have to kind of check yourself that there's nothing you miss, because the last thing you want to do is take things off, wash your hands, step out and realise there's something else you need to do, which I haven't done that on this shift yet, but I did a lot last time. So make sure all the patient's vital signs were good and correct them if we need to, for example, giving them oxygen while we wait for the investigations. We get the blood test. The chest x-ray as well is super important and can pretty much be diagnostic in a lot of these patients or give us an idea of how much the illness is affecting them. Once we have all the investigations, my hospital has a tool, basically like an algorithm, a flow diagram, to figure out whether a patient is best suited to be going home, best suited to be on the ward, or even if they need to go to ITU. Clearly that guideline is super important, but you also need to use your own kind of clinical acumen to work out what's the best for the patient given their individual circumstances. One of the things we are doing a bit different as emergency doctors is normally we refer to the medical team when someone needs to come into hospital, and the medical team do all the ward paperwork. To help the resources with them, the emergency doctors are allowed to fill out those forms. Now, I haven't done like a ward medical job for many years. We can take that burden off some of the medical team, and that's brilliant. I've got a couple of hours left on the shift. One of the patients I've seen that I talked about that flow, I'm just waiting for the investigation, so I'll go back and see them and make a plan for them, and I'll see you later. There you have it, another shift done. And I can say the Q word now because I'm finished. It was pretty quiet. You have this ebb and flow of patients, so we just happened to have a good night. It would have only took a few patients to make us very busy because there's only 3 of us on the COVID side. Now, one of the other doctors was actually one of the people I taught when they were a medical student, so it's nice to see those people coming through. A cool thing to know that some of the people that I taught are out there doing a super job. So big shout out to any of the people that I taught when I was a teaching fellow. One of the things you forget as well, from a patient point of view, it's pretty scary, us all wearing masks and gowns and goggles. So we're trying to find ways to make it more friendly. I tend to say to patients that apologise for the get up and say, I'm smiling beneath this mask, but we're also writing our names across the front. I know I've seen pictures of other doctors on social media having photos stuck on the front. I think that type of thing is a really good idea because people are naturally going into hospitals bad enough. Going into hospital in a pandemic, being very worried is even worse, and then seeing everyone gowned up and these scary masks is even worse on top of that. Overall, it was a good day for me, but you got to take these good days when they come, because I know many places around the world are struggling and will have difficult days ahead of us. But feeling good for all the patients that came, we did a good job for, so I'm going to end on a high there. So thanks again for all the support, and I'll be back soon.